severely neutropenic. And there's another case in CCU who have corona also, I think so, the OC43, but we don't think so that's the problem with him. So I'm going to talk today about the Middle East respiratory syndrome coronavirus. So first it was diagnosed in the kingdom in 2012, and since then we have more than 870 cases all over 20 countries. In Europe there's 7 countries, I have to change this, that reported or confirmed cases. I have a map here. If you see the dark purple where they have the highest number of corona, and it's unfortunately in the kingdom, and the yellow are the imported cases, and all imported cases unfortunately is from also the kingdom. So you can see it was imported twice to the United States, to Algeria, Egypt, and those with light purple, those with probable or confirmed cases also, but not, the numbers were almost 3 to 5 or 1 to 2.
But they were not imported from, not exported from.
No, this is not. This was not. No,
it was there. Yeah.
No, this is not. This was not imported cases. This was either suspected or confirmed cases of corona. Iran, Yemen, and Tunisia, as well as other countries in Europe, France, United Kingdom. So it's usually the problem with MERS. It had this feature that can survive for 48 hours in certain degree, temperature degree. So it's like almost MRSA, like bacteria. When it can survive on surfaces for 48 hours, so you touch the surface, then you touch the mouth, eye, or nose, then you get the infection, unfortunately. And also from its feature, it's a good thing that it's sensitive to heat, to ultraviolet light, and to sometimes alcohol and detergent. So that's why we encourage people who go for home isolation to clean surfaces more frequently, and hopefully they don't transmit the cases to other people. Clinical presentation, usually we don't have those patients who are asymptomatic. Asymptomatic, how they found it? They found it in healthcare workers when they did a survey that had exposure to one coronavirus, and they had like 3 or 4 healthcare providers that didn't have any symptoms at all. Okay, those who present to us, they can present with flu-like symptoms, mild, to the OPD, or they can present to the emergency or ICU with severe ARDS, septic shock, or DIC, and it's more severe in immunocompromised patient as usual. Risk factors, they found diabetes mellitus is one of the in percentage one of the highest risk factors and the comorbidities: hypertension, cardiac disease, chronic kidney disease, immunocompromised patient either on immunosuppressive treatment or other risk factors are the epidemiological clue. So very important, we ask patients if they have close contact with confirmed or suspected cases of corona. The other question, if they have exposure to camels. They found out, this is the comorbidity, you see diabetes is 53, hypertension 50, and no underlying condition is 23%. So, history with contact to camels, now they found this, the primary source of infection in the kingdom is from camels. The primary, you'll get used to it. So the primary source is camels. And they found it's proven that it caused infection to human. So usually we ask if the patient had exposure to camels within 2 weeks. This is direct exposure. The non-direct exposure, it can happen, and you ask the patient if you know someone, or if you have contact with someone who have been exposed to camels. So it's by 2 ways. Either direct, we are exposed to camels, or you know someone who exposed to camel within 14 days. Also we have to ask, يعني يقول لك أنا والله I have camels, I raise camels, any camels.
Contact.
Any contact, close contact, touch, So yeah, that's a good question. So even we asked them if they ate undercooked meat, because cooked meat is fine, or unpasteurized milk. Many people, you know, they sell it outside. They go and they drink unpasteurized milk. Pasteurized is fine.
Can corona come under through the GIT or
Yeah, it can be. This is one of the transmission. It can be, yes. So this is to your question, transmission, limited human to human transmission, because we see a lot of cases, and then when we do a survey, you know, you don't find that transmission. We have isolated cases here and there. So either direct transmission, very close, someone sneeze or cough, and there's also evidence of airborne transmission. That's why we do airborne precautions and contact in a patient with this with coronavirus. Indirect transmission, as you said, like it can survive for 48 hours in certain degree, in certain temperature. So you touch the surface, then you touch either the mouth, nose, or eyes, and you can get infected with MERS coronavirus. This is updated from 18th of February 2000, so yesterday, and I think so they had 2 in Dhahran and 1 in Khobar new cases. No, 1 new cases. So the total cases since 2012, 897 cases so far. 377 died, so the mortality rate is 42. This is huge, really. When you have almost a half of cases, they die. This is why they're concerned. But if you go in general and can count 897 to the population of the kingdom, you know, it's like 0.0004. It's not that high. And this can explain also the transmission is not really between humans, it's not that high for some reason. Just 40 new cases with 11 mortality from February 11 through February 18. So in the last 7 days, we have 40 new cases. And we learned from last year and the year before that the peak is in this time. I'll show you a map. If you see in 2014,
Burj Khalifa.
huh?
Burj Khalifa.
Burj Khalifa, والله. This is between March and May. See how huge it was, the number of cases being in this time only. So this is like in 1 week, it reached 100 more than 100 cases. And look at the mortality rate in the light blue, the sky blue. So, and we're suspecting between February and the beginning of June that there will be a peak also.
Starting now.
Starting now, unfortunately. We have already 40 cases. MOH, so Saudi MOH, so in our Saudi MOH, what they had case definition for suspected corona, and they made it because, you know, these fatalities very high. 4 definitions they made. The first definition: any patient who comes with fever and community-acquired pneumonia, okay, or ARDS. Either this is by clinical or imaging evidence. Number 2, patients who are in the hospital, like let's say the patient is in ICU and he had hospital acquired. They mention here healthcare associated, but also if he developed hospital acquired pneumonia, then we suspect also this patient either by clinical or evidence suspect this patient to have corona. Definition number 3, these patients are usually in the ED or the OPD. They have a temperature of 38 or more, and almost 98% of corona patients will have a fever. Okay. Then they have body ache, headache, diarrhea, either with respiratory or without respiratory symptoms, or unexplained leukopenia, or less than WBC less than 3,500, and platelet less than 150. So you have to have all these 3: fever, flu-like symptoms like nausea, vomiting, red ache, and also lab unexplained leukopenia or thrombocytopenia. And also they had a case definition for, and it include persons and healthcare providers who had protected or unprotected exposure. So what they mean by protected exposure, that means within 1.5 meters, you're wearing all the precautions, you're wearing a glove, you're wearing a gown, you're wearing the N95 mask, so you're exposed, protected exposure. Non-protected exposure, they're not using even one of these precautions. And who comes with either upper or lower respiratory tract infection like rhinorrhea, sore throat, cough, shortness of breath. So for suspected or cases, the recommendation in intubated patient or even patients who are sick to do a bronchoscopy, so to do a BL. The other option is to do a deep trach aspiration, and now we have to send it. They said to Hadda. They called us and we called the lab in Hadda and said, okay, we need the sample not open. So if we want to take, we'll ask the people, pulmonary people to do, please, or us, we'll do a deep trach. We have to take more than samples. One, they don't want it not to be touchable. We just take the sample, close it, send it to the lab will take care of it. And then one, we can send it to our lab for, we have the kits for corona, so we'll tell them do a respiratory panel. This is also the recommendation. They say just don't think it's only corona, think about H1N1, and we have cases, influenza A, it's the season, influenza B, it's the end of the season. Also bacteria, streptococcus. So when we do our respiratory panels, our lab will take care of that. And the result should not take, we should receive it less than 14 hours. So if we don't receive it within 14 hours, we have to call the lab. There's something wrong.
Bronchoscopy is mandatory in this case.
But it's better to do a deep. It's better to do a BL to get high yield or a deep trach aspiration.
When the patient is
Intubated. Yeah, the patient is intubated. You can do it. If the patient is, let's say, he's not intubated, the recommendation is to do to sample from the nose, nasopharyngeal, and from the oropharyngeal. So you take 2 swabs, one from the nasopharyngeal, and it should be someone who know how to do it, either a nurse or a physician, and then an oropharyngeal also, and you put it in the same tube. Both. Close it, and this should be sent to Hadda by the lab.
And this is alternative to the bronchoscope or bronchoscope.
Let's say a patient who doesn't need bronchoscopy or
Some patients no need for bronchoscope.
well, in ICU, most of them they will need a deep trach or bronchoscopy. I think this is mostly applied to patients who are in the clinic or in the ER, and they come with these symptoms and we're suspecting corona. But
Some patients in the ICU, but not intubated.
so we can do the nasopharyngeal.
Yeah, no problem. Yeah, you can.
If you have sputum, that's good. It's in the lower. We like the lower to be from the lower. But let's say he doesn't have sputum, and we're suspecting. So we can do a nasopharyngeal and an oropharyngeal swab. Patient was trained to do it and put it in one tube. You don't need 2 tubes. And send it. It's painful. You can do another one and send it to our lab. So it's in here and here. And this is for contact. Infection control will take care of this part. So this is the triaging that we made, me and Dr. Malik and Dr. Mustafa. This will be here. So what we did, we have in the OBD, there's OBD1 and OBD2. We have, we call it a visual triage nurse. So a triage nurse, there will be a reception there with the phone and everything. She will ask everyone coming to the OBD1 or OBD2 about acute respiratory illness symptoms, flu-like symptoms. So if they answer yes, we have on the right side, on the left side, close to the door, now we made the screening, we call it the screening acute respiratory illness room. It have HEPA filter in it. We made they're gonna make the door for it also. So this is only for patients who suspected to have acute respiratory illness in OBD1 and OBD2. There's 2 of them. These patients will wear a surgical mask. They have to wear a surgical mask. They're going to educate him for cough and hygiene etiquette. So they're going to use sanitizers also. And there will be push-or inside that screening area. So what the nurse do, they're going to escort him to that area and they're going to call the physician. Whoever is the physician OBD, let's say the physician is ophthalmologist, he's going to call the physician and say, look, we have a patient suspected in this time, please take the precautions. So what they'll do, they'll do droplet and contact precautions, because we don't know, it could be simple. In the OBD, the second step that you see here, after they wait, they have to inform the physician, the primary physician, then the primary physician will assist the patient. He's gonna wear all the precaution surgical mask, and we're not mixing this patient with other patients in other waiting area. We just want to minimize these patients with suspicion. So he's gonna go to the physician, and he will ask him, "Do you have a fever? If no, then this is less likely. Do you have pneumonia symptoms?" And then they can examine him, see if there's any evidence clinically of pneumonia. We said we don't want any X-rays in the clinic. So if he answered the patient to the physician yes for fever or pneumonia, immediately he should be sent to and call ED to be sent to the screening area or the waiting area in the ED after speaking to the ED physician. Portable X-ray will be done outside. We have a room outside it's on the right side. We just get into and there will be 2 beds. And they're not going to be mixed with radiology department patients. The portable X-ray will be there, and they'll do the portable X-ray if they're suspecting also. So if he answer yes, the primary physician, the patient should wear a surgical mask all the time, should be escorted to the emergency department. He will be assisted by the emergency department. They're gonna see if he meets the 4 case definition criteria. If no, then he will be managed accordingly. So this is not suspect corona. If yes, they're gonna inform. This should be up. They're gonna inform infection control, and then they're gonna assess if he need admission. Now we're suspecting he meet the case definition criteria, the 4 case definition criteria. Now we're gonna ask, does he need admission or no? If yes, then we're gonna isolate the patient in a negative pressure room with airborne precautions. If no, we can isolate the patient at home. He doesn't need to be admitted. However, we need to take a nasopharyngeal swab and send the patient home. And if it become positive, we're going to continue with the MOH algorithm. We also provided the information for the problem for infection control, so they're going to be contacted. The recommendation is to do a nasopharyngeal swab or an oropharyngeal swab in a negative pressure room. This is the recommendations. If not, we have a HEPA filter room. This is the algorithm made by the MOH. This is for suspected cases. Let's say the suspected case now it's positive. What we should do?
في سؤال بس. Say إن عندي suspicious of case of coronavirus. Could be a carrier or could be an infected patient already with manifestation and symptoms.
Yeah.
في pathway for decontamination of this patient before going to special pathway. يعني something nasal, oral decontamination.
No, we don't have decontamination. Well, I wish we had decontamination with the apple. You're gonna use it. No, there's no documentation. We just have to educate the patient for hygiene and cough etiquettes, and also they have to wear surgical masks all the time until we get sample from them. But there's no documentation, unfortunately, for this coronavirus. So now, if they meet the criteria, if it comes positive, what we do? We're gonna admit.
Sick or not sick?
Yeah, you're gonna ask if we assess if he need admission or not. So if he doesn't need admission, what we'll do? We'll go home with home isolation. We'll give him all the structure of home isolation, but you don't send him home immediately. The next step you see if the home is suitable. So what it means by suitable, I'll go through this definition, meaning that the patient have easy access to hospital. You don't want to send patient who lives 60 miles or 60 kilometers away and they don't have access to hospital. There should be an adult caregiver for that person who can call anytime. And also he had to have a private room and a private bathroom. So if he filled the suitable criteria for home isolation, they can be sent to home, this patient. And what we do, the infection control will follow up, and they will do weekly nasopharyngeal swab and oropharyngeal swab, weekly. So let's say here we repeat the test every week, and we can discontinue isolation when it becomes negative, if it's positive now, because it's positive. So when to discontinue home isolation? When it's positive for one time and patient doesn't have any symptoms for 48 hours.
Negative.
Huh?
Negative for one time.
One time. You need one time to stop home isolation. Say you're safe, you can go with the community. You don't need to wear a You can share bathrooms. You can, because also there's an instruction, not to avoid crowdedness and other things. So let's say it's not suitable. The home is not suitable. What we'll do? We have to admit hospital. But now there's another route. They say if it's positive, you have to send him to King Abdullah Medical City Complex in Jeddah. All positive cases should be transferred. We have one ambulance with a negative pressure. So any case that's positive doesn't stay here and need admission. They have to go to King Abdullah Medical. They have almost more than 70 negative pressure rooms, isolation, I think. So they have ID physicians there, ICU, quick for corona. I don't know how much ECMO they have, but they said they have many ECMO. This is the pathway. Let's say the patient is positive and he have pneumonia, plus or minus shortness of breath, plus or minus low OSAT. So this patient needs to be hospitalized. Then what we do in hospital? He's in ICU now. He have pneumonia, evidence of pneumonia. He have low SAT. He have, let's say, and he's in the ICU now. So what we should do?
It can be in the ward.
It can, if it's a negative pressure.
If the patient no need for ICU, but he can be in the ward.
He can be in the ward. He can be even home. So
Well, I'm not talking about that.
he need admission. He have some pneumonia, infiltration.
Some pneumonia.
Okay. So he can be in the floor if he doesn't need negative pressure room. If they have negative pressure room, he can be in negative pressure room. And what we do, we have to
There's
go.
indication to go to the ICU. We'll start from this voyage.
Yeah. Indication, general indication, like any other indications. Low SAT, patient is not doing well. And what we do, we have to collect even if it's positive, we have to collect every 3 days until it becomes negative and he doesn't have any symptoms anymore. If it's negative, has any symptoms, you can discharge him home. If it's still positive and patient is doing well, he's fine, he's improving now, he doesn't have any more importation, he's improving, we can discharge him home if the home is suitable.
He come with us, and this is suspicious one. We don't know he is positive or negative. We put him, and we will wait for the result.
So you're here.
Like number 6.
Yeah.
Yes.
So you're here.
Yes.
So you don't know the result. Let's say negative or we don't know the result. That's right. So
But
what
I
you
put him in negative pressure.
because you're suspecting.
Okay.
Any suspected case have to go to negative pressure. Even if it's negative. And let's say you're highly suspecting cases and it's still negative. And you did the repeating, they said every 3 days, and you're repeating and still negative. The other options, what you do, call, if you have patient, call for pulmonary to do a bronchoscopy. And the good thing also we can do here in our hospital, you can do urine, stool, and blood PCR for MERS. And they found by studies that it can present death.
Can.
So what I'm going to do if I have a suspected case, really, what I'm going to do, I'm going to send all these. Because it's shown that it can be in stool, it can be in urine, it can be in blood. So why not sending it? We have a lot of kits we want to use it.
We need to try to we have patient come to us and we don't know this is corona or not. But we have a suspicion. We give the patient room and we are making contact for patient droplet precaution until the result comes. When the result will come?
Not droplet. Now they change it. The last one in June, they say airborne. In July, they said critical or non-critical.
Yes.
Then they came back after type problem. They say all patients will be on contact and airborne isolation. So no droplet. All patients.
When they expected the result will appear?
Within 16 hours. Maximum 14 hours, they said. If it's not, we have to call Hadda, there's a problem, call the lab and say there's a problem.
Sometimes this is more than this.
No, it should not. Now we spoke to them, we spoke here, and now we called also FedEx. Usually they will collect one in the afternoon and one. Now we said we have an agreement, MOH have agreement. So now, from the last 3 days, they're coming every 2 hours. Within 2 hours they collect it. Anytime. You collect the sample at 1 a.m., they're going to come 1 a.m. Within 2 hours. This is an agreement.
I don't think it's attending the regular practice?
No.
Maybe 2 hours, 6 hours?
We're meeting every day because of this. Every day, and we're asking the lab what happened. You know, there was from the beginning of this
Okay, this
week.
is new era present in the hospital.
Yeah.
Or this is before?
No, we're doing this week. There's a lot of you saw how much rolls up and things. There's a campaign.
We have a patient suspected corona in number 6. They stay 1.5 day.
So what do you do?
Today in the morning, they say to us it's great.
It was negative,
Or negative.
and you're still suspecting?
No, class. In the morning, they say after 1.5 day, 36 hours.
No, it should not take that long. Call the lab. Now what we
I show
do?
you that we say that this picture is interactive.
So once you,
I have a patient like this.
yeah, I understand. Once you pass the 14 hours, call immediately the lab, Dr. Wafa. She should have the result. Now what we did also, we called them and they're gonna come. We're gonna have access to the lab there.
طيب سؤال دكتور as far as
We call infection control on this proper number, and they're gonna organize
so
everything.
his responsibility to track the result. Should I call him?
Track the result, coordinate things, call MOH, and
Right. Result come to me negative. I can stop the Tamiflu and the precautions or no? How? Who will document to stop this?
so if it's come negative and you still, because it can, you know, the yield sometimes not that high, and you're still suspecting this is corona. Let's say you're still suspecting.
I suspect chest infections and leave the patient.
You're not suspecting that it's corona.
Impending.
So what's the risk factor? We'll ask the patient, does he have that camel exposure again? Did he eat, did he have a father or a son or that have camels?
My patient, we're talking about patient.
Epidemiological clues.
The patient is sitting in the home and he is 88 years and never go outside. And he is stay in the home, he is not going outside.
And we're thinking this is aspiration pneumonia, right? We're thinking this is maybe aspiration pneumonia or something?
No, because the patient is low resistant and he is...
And so you're
More highly suspicious.
so it's not that highly suspected. Probable cases, and you have one negative, and that's enough.
But if suspicious, should be another
Highly suspicious.
If you're still suspecting, you repeat it after 3 days.
after 3 days. So stay
Look,
and it has...
it's negative, and still you have pneumonia, CD1, mean case definition number 1 that we said, healthcare associated pneumonia, hospital pneumonia, or community-acquired pneumonia. So keep in hospital, repeat MERS test every 3 days, because he's still here, you're still suspecting. Then repeat for every 3 days. Say the test is negative, and patient is well, but he will not be well in ICU. So then we go to this.
Tamiflu will change, not to change your result?
Tamiflu,
No.
I hope it will change. We'll use it.
لا if you use Tamiflu and they take the test. It's different that the patient...
No, Tamiflu doesn't work on corona, unfortunately.
Oh, no.
No, it works on influenza. So Tamiflu doesn't work on corona. They have tried in Saudi for treatment. They have tried, I think, on 5 patients. There was a study. They were trying the hepatitis C interferon, and the ribavirin. All of them died. But they said they used it after 5 or 6 days. And there's another study that Tamiflu, you know, these patients, you have to put them on Tamiflu and empirically on antibiotics. This is the recommendation even in the guidelines. Yeah, community acquired. So we will use the as community acquired. Let's say in the recommendation, in they say use ceftriaxone and macrolides. They say for community acquired. If the patient have comorbidity, you want to use something, you use, or you're suspecting gram-negative, or have colonization with MRSA, you can use vancomycin and cefepime to cover gram-negatives. This is the recommendation. So all these patients will have to be on empirically on antibiotics and Tamiflu, as you said. We have to start it and start high dose 150 BID, and then we'll check for this corona. You can do it every 3 days, especially this time between February and we know we have only in 7 days 40 cases. Can you imagine 2 of them or 3 in Jeddah? So in this time you have to be really suspicious of corona. Repeat the test. There's no harm to repeat the test. If you're not sure because you took it from the nasopharyngeal and the patient deteriorated in the ICU, go with a deep trach or go with a bronchoscopy. So this is the isolation.
دكتور معتز طيب if based on the epidemiological data and risk factors for my patient, and his
Gloves, gown, this is contact precautions. Protect our eye either with goggles or eye protection, and also N95 mask. And hopefully you had the fit test. If you have hair in your face, huh?
and the people with the bird.
Yeah. If you have beard or hair in the face, they advise to use the paper, which is the respiratory purified air. Also, we advise all patients to go with the cuff. This is the infection control. Patient transplant. Always when the patient is transported, going to ICU, coming from ICU, they have to wear surgical mask all the time for suspect cases. And also, they have to notify you. Let's say it's in the ED, they have to call ICU. Dr. Jamal, we have a case suspecting corona, so he would also take precautions and drop it until he's airborne precautions. This is speaking about patient transport. Always wear surgical mask and ensure that healthcare workers and transporters wearing also gowns and gloves. This is not the powered air purifying respirator, but this is like a face shield. I don't see it here. But these people with facial hair, some will ask, if I have facial hair and I don't have this, should I wear N95? Yes. Maybe it doesn't fit, it doesn't work, but we have to use it.
And the recommendation here, usually previously they were prohibited to use N95 for airborne, yeah.
For airborne?
For any airport.
If
And
you
even
have-
for TB, for others, actually one they refused by infection control people. It's
To-
like
to-
4 months ago.
Because it will not be that, but
Yeah.
they said use this or don't go to the room.
Exactly.
Let someone.
So this is what they recommended.
Yeah,
And we don't have it in the hospital.
We don't have.
We
They
don't
said
have it
they
in
have
our
it.
hospital.
They said they have it too. This is what they said. So call infection control always and they can.
Do you have it, Ahmed?
Infection.
No.
So the other thing, nurses or physicians, how to remove these. So what we should remove first? We should remove the gloves, because this is where we usually touch things and get contaminated. So remove the gloves first, then we remove the goggles, we remove the gown, and the last one to remove is the mask. And they say don't touch it from front, on the side, the straight of the side. So just remove the before either in the anteroom or outside.
Hand hygiene before,
And of course
between.
we have to apply the 5 moments. Of course, this hand hygiene. I did go. I tried to make it more clinical. I think so. Dr. Mustafa, now, mashallah, he went through on the last round through infection control. So this is for also home care what we do, and this is. As I said, if it's suitable or not suitable, this is the recommendation by MOH. There should be a primary caregiver, adult. Patient has to have a private room and a private bathroom. And also we instruct patient at home to separate themselves from other people, to call ahead before visiting doctors, to wear a surgical mask when they're leaving outside or exposed to other people, and to adhere to respiratory hygiene and cup etiquette, and avoid sharing household items like toothbrushes or other things. Frequent hand hygiene. Post-exposure, let's say healthcare provider who had exposure, either protected or non-protected exposure, what we should do. So we have to track all these healthcare providers. What we tell them to stay home? No. We will tell them if you have symptoms, call infection control or call the employee clinic. But if they don't have symptoms, they can continue working. So, and they will be assessed by employee clinic and infection control for 14 days after the exposure to these suspected corona cases. That's it. It's more of a clinical more than anything. And